Hello, my name is Clara. I'm a child neurologist from the University of São Paulo, Brazil. And today I'm going to say a little bit of practical advices for daily life. The point is to answer some of the questions that you guys sent to us. Thank you for that in advance. Such as, how do I know if my provider has sufficient knowledge about LAMA2 related dystrophy, for example? First of all, I want to justify the reason why I'm presenting this to you. So Brazil is a really vast nation. We are the 7th largest population in the world, and we're also a very wealthy country, actually. And currently, we rank as the 10th largest economy globally. However, Brazil is also one of the most unequal countries in the world, and we have extremely unprivileged patients coexisting alongside very affluent populations. So I share this context to frame my presentation today. Although I'm neither personally affected by LAMA2 related disease nor a caregiver of a patient with LAMA2, I currently follow more than 100 patients with LAMA2 from remarkably diverse socioeconomic backgrounds, ranging from those with access to the highest standards of medical care and cutting-edge assistive technologies to those living in conditions of extreme deprivation, unfortunately. But this experience has given me a broad and practical overview of what is truly essential and what generally makes a difference in the day-to-day care of these patients. And I think that's why I was invited to do this presentation, which I am extremely honored and grateful. So, how do I know? The thing is, there are approximately 8,000 diseases classified as rare worldwide. However, medical training in most settings focuses primarily on the management of common conditions, such as hypertension, diabetes, and asthma, pneumonia, sometimes cancer. So, being straightforward with you, answering one of your questions, no, most of the physicians are not specialists in congenital muscular dystrophy. So I think that's important to say that one of the fundamental pillars of appropriate follow-up and treatment for individuals with a rare disease in the active is, most of all, the active engagement of patients and their families in understanding and managing the condition. You have to be the specialists yourselves. Obviously, every patient needs to have and should have at least one annual consultation with a specialist in LAMA2 related disorders. And for a significant portion of their care, they will inevitably be seen by non-specialist physicians as well. And that's why at that point, it's important for patients to be empowered. And that becomes extremely evident. Families must understand the basic and essential needs associated with the disease. That is the focus of my discussion. So to know if your provider, your physician, and other medical care providers and nurses, PTs, phonos, to know if they're good, they're probably connected to a huge center specialized in rare disease with a neuromuscular center, so you can check that online. But you have to know that once you need to see other doctors, other physicians, and go to the ER, for example, it's extremely unlikely that that physician in the ER is also a specialist. And that's why I wanted to do something really practical for you guys today. And the first thing I want to say is that the pulmonary care is the first essential topic. Because, as I said, it's not feasible to train every physician in the world about LAMA2 in a short period of time to provide what you need in the next, for example, 2 to 5 years. However, we can reach a meaningful number of families through patient advocacy organizations such as Forsara. And what patients need to know and what they should actively share in this responsibility in the patient's care is what I will outline right now. So, about pulmonary care, first of all, we need to know how to recognize signs of respiratory impairment. This is because the respiratory complications represent the greatest risk of hospitalization and life-threatening events in individuals with LAMA2. So this topic will be divided here in 3 topics, actually. So how to recognize signs of respiratory impairment, how to determine which assistive respiratory technologies are needed, and what to do in an emergency situation. So to recognize signs of respiratory impairment, you need to see the clinical warning signs, which are recurrent chest infections, signs of respiratory fatigue, such as rapid or labored breathing, shortness of breath, interrupted speech. One thing that might not be easily connected, but it's also related to hypoventilation in the night, is morning headaches and poor or fragmented sleep. The patient that wakes up like a lot of times during the night or snores a lot. Patient that actually has difficulty gaining weight or is losing weight, for example. And so these are clinical warning signs that something is going on and that you have to prove with diagnostic tests such as spirometry and polysomnography. That's the test that you do during the night. And this test should be done annually. So it's important to say that not all the patients are going to be able to perform this spirometry because it's actually a really hard to understand axillary exam. But if they cannot, then we can always do the clinical part alongside with the sleep study. We also need to determine which assistive technologies are needed for these patients. So any child with clinical signs of restrictive ventilatory impairment or nocturnal hypoventilation, just as I said before, and any patient with abnormalities that are clinically relevant on tests should use non-invasive ventilations. I mean BiPAP, not CPAP, BiPAP. And in very young or very small children that are extremely low-weighted, for example, standard BiPAP devices may not fit properly. In such cases, more advanced ventilators such as portable life support ventilators like Trilogy-type devices may be necessary. And it's also important to say that a proper mask fitting is essential for comfort, adherence, treatment effectiveness, and they should be selected individually as there are really different types and sizes available. It's also important to say that not only the BiPAP is essential, but patients should be able to have airway clearance and to be able to cough properly. So ideally, any patient with weak or ineffective cough should also have access to a mechanical insufflation-exsufflation device, I mean cough assist, especially during respiratory infection. That may be what prevents the patients to go to the hospital, for example, and allow the families to manage the respiratory infection in their own home. This will help them to prevent atelectasis, secretion retention, hospital admission, as I said. But the thing is, cough assist can be really expensive, and not all the patients are going to be able to have access to that technology. And sometimes in Brazil, for example, we use the Embu bag. It's not the same, but it helps a lot to prevent atelectasis and also helps airway clearance. So that may be a cheap option here. And what to do in an emergency? So always carry a medical letter from the treating physician, the one that is in fact a specialist in LAMA2, to explain the diagnosis and to say what's the specific respiratory management considerations that the physician in the ER needs to know. Everybody has also the need to know that oxygen therapy should never be used alone. It's not that oxygen itself can be a problem for the patients, but oxygen must always be administered together with non-invasive ventilations. Because the problem with the patient is weakness. So if we give only oxygen, we might worsen the carbon dioxide retention. And that makes the patient sleepy, and sometimes they are intubated and go to mechanical ventilation because of the carbon dioxide, not because of the infection itself. And that's what we want to prevent. And remember that sometimes, depending on the ER that you're going, you're not going to have a BiPAP device available for the patient. So if you have one, you should always carry it with yourself when you need to go to the hospital. I think that's the most important part. But we cannot forget the motor care. That sometimes it's a major point of the discussions because we really connect quality of life with the ability of walk, for example. So one of the huge questions that people ask me is, how much physiotherapy should I do, and what's the best kind of physiotherapy that I should do? So it's important to say that for many years, it was believed that individuals with muscular dystrophy should avoid movement altogether, as physical activity was thought to accelerate muscle degeneration. Today, we understand that sedentary behavior is also harmful. So the key is to find balance between movement and protection, maintaining regular stretching and gentle activity without overexertion. So the key is finding the right balance. From what we know, following up the patients with, and also with the small amount of data in the literature, we understand that fewer than one physiotherapy session per week is usually inefficient. And daily intensive physiotherapy is also a problem because it represents excessive strain. It's also important for the patients, again, for the families here, understand what kind of movement and stretching they need to do, because it's hard to find physiotherapists specialized in neuromuscular disorders, the same as happens with physicians. So what I do in Brazil, and I think it's a practical strategy, is to establish a comprehensive therapeutic plan at a specialized center at least once a year. And then this plan can be implemented locally by another physiotherapist in the patient's home city. But if it's a small baby, a toddler, a small infant, it's probably gonna be needed more than one meeting a year. At least 2 visits would be ideal. And we should also talk about the wheelchair. So choosing the proper wheelchair requires time and careful planning. The wheelchair is not simply an equipment, it's an extension of the patient's body. And the patient is gonna spend a significant portion of their time in it, so we should prepare it well. The patient should be seated in the best possible way to align and prevent scoliosis, but also to allow this patient to do most of the activities that he can do. So if the patient has sufficient upper limb strength for self-propulsion, maybe we can use a wheelchair that's lightweight and the wheel is correctly positioned for optimal hand reach and efficient movement. But most of the cases, a powered wheelchair is often the best option when available. And again, the positioning is crucial, but we have to combine autonomy and posture. So the patient not only is well postured and prevents scoliosis, but also can function well. That's the prior goal. And Also, when we talk about motor, we have to talk about managing contractures, which is also quite hard. So contractures can be particularly challenging. Orthoses are often necessary to maintain muscle length and prevent worsening, shortening, to allow that stretching to be effective, and also to prevent pain. So what we know here is that orthoses typically need to be worn for many hours per day. So that's why we usually prescribe it to be used at night, because then the hours pass more smoothly. But if that's preventing the patient to sleep well, then perhaps the best option is to use a day. So, and that's all right as well. Another really good way to stretch legs, especially, is supported standing, for example, parapodium, tilt table. And these devices can often be adapted so the patients can stand while engaging in another activity, and so the time won't pass so slowly and tediously. And surgical corrections of contractures are rarely indicated, only if the patient's in pain or if the patient's gonna gain functionality after the surgical correction. Another really important topic that I speak a lot with the patients here is nutrition. So there is currently a strong trend toward dietary supplementation, both among patients and unaffected individuals. But scientific evidence supporting routine supplementation in neuromuscular disorders and in other scenarios as well are very limited. So it is important here to remember that everything requires time, family and patient's energy, and obviously financial resources. And the families are already managing an extremely demanding routine. So we should prioritize carefully. But in general, we should always have a balanced diet. And for some patients who have difficulty gaining weight, high calorie and high protein oral nutritional supplements may be indicated. But when we talk about creatine and CoQ, there's still really just a small amount of data, and it's not conclusive. And here in nutrition, we can also add information about bone health. So we know that the patients with muscular dystrophies have an increased risk of osteopenia and osteoporosis. And that is an increased risk as well for fractures, which is not good. Sometimes it's related to pain or to surgeries or to the loss of some motor functionality. For this reason, dietary calcium intake should always be reinforced, especially through milk and dairy products, because calcium obtained through diet is usually absorbed more effectively than calcium from supplementation. And that also is less related to complications such as kidney stone formation. We usually also supplement all the patients with vitamin D, so that's also important, but we always have to evaluate individually based on laboratory results and the clinical context. And as we know, patients with LAMA2 also have a higher risk of hypoglycemia, so we should avoid prolonged fasting, particularly during episodes of infection and when metabolic demand is higher after surgery as well, for example. And these patients may also require high-calorie nutritional supplements to help prevent hypoglycemic episodes. And it's important to also point that a subset of patients will require gastrostomy for the G-tube for better control of weight, dysphagia, and or recurrent hypoglycemia. And when this is indicated, I also want to say that it should not be perceived as a failure. If the patient needs it, it should see as a step toward improving safety, nutritional stability, and overall quality of life. And the major point, the end topic that I want to say here is that quality of life and autonomy go hand in hand. So each patient is unique. It's not just a whole group of equal patients with LAMA2. It's essential to identify individual priorities and focus on what is truly important and what will truly improve that person's daily life. And sometimes small adaptations can make a huge difference. And for example, using lighter utensils, adapting handles, adjusting table height and positioning to promote, for example, independence during meals. We can also make daily life at home easier, for example, widening doorways, lowering light switches to wheelchair height, improving accessibility in bathrooms and common areas. And the goal is here always the same, to maximize independence, functionality, happiness, and dignity in everyday life. And I want to say in the end that every patient is a universe and contain multitudes. I've seen this movie called Life of Chuck, and it really struck me as something that a message that I think it's quite important and real, and that's what I wanted to share with you.
I'm wonderful. I deserve to be wonderful. And I contain multitudes.
I contain multitudes is true of all of us. It's to say that
every person you've ever been lives inside of you.
All of us have these gifts. Everyone has potential that is unrealized.
we are so many things, that inside the soul of every human being is an interior world.
I contain multitudes.
You contain multitudes of power, of beauty, of truth. You just have to seek it.
The reality is that within all of us, there is this beauty.
It's a reminder that we are all full of infinite possibility.
The entirety of a human is I contain multitudes.
It's just a matter of you finding it for yourself.
One might imagine that it's easy to feel reduced by life. Oh, I'm just the job I do. I'm just the role I have in the family. No one is one thing. We are every experience we've ever had, good and bad.
We all contain multitudes.
Every single human being is so full of people.
We are our joy and our pain, hope and our fear, our experience, our perspective. We don't have to keep it all inside. Part of the act of love and the act of living is that we share our internal world, if we want to, with those we love. And maybe the constellations will talk to each other.
And that's it. Thank you so much for your time. I'm available to talk to you later in the round table for hopefully. And thank you again for the organization, for the invitation. And again, I'm extremely grateful for everything.